So hello and welcome. Today's webinar is presented by Ann Gavick and produced by the American Association of Cardiovascular and Pulmonary Rehabilitation. Ann will be addressing how rehab professionals can use functional capacity performance measure for cardiac rehabilitation. My name is Hannah Muirhoff and I am on the education team for AACVPR. It's my privilege to introduce Ann.
Thank you, Hannah, and good afternoon. My name is Ann Gavick, and I am a clinical exercise physiologist and the manager of cardiac and pulmonary rehabilitation at Northwest Community Hospital in Arlington Heights, Illinois. I'm a past president of the American Association of Cardiovascular and Pulmonary Rehab and also a member of the Quality of Care Committee for AACVPR. The Quality of Care Committee has been charged with developing performance measures for use in the measurement and assessment of quality in cardiac rehabilitation. During our time today, I will review the performance measure for improvement in functional capacity in cardiac rehabilitation. I would like to acknowledge Dr. Ray Squires from Mayo Clinic Cardiovascular Health Clinic for his work in developing this performance measure. I have no financial relationships to disclose. During today's webinar, I will first take a quick look at why it is essential that we measure quality in healthcare and what the role of performance measure is in that process. Then we'll focus specifically on the functional capacity measure, including the importance and scientific evidence behind measuring functional capacity. I'll review the description of the measure, including the numerator, denominator, and exclusions, and describe the tools that can be used to measure and report changes in functional capacity. And then we'll conclude with a couple of examples. In today's healthcare environment, more than ever before, we're being asked to provide evidence of the value of the services we provide. Value, of course, includes both cost and quality, so while we have to keep a close eye on cost containment, we also must importantly show evidence of program quality and outcomes. It's not enough to say anymore that we have a good program or even to provide research evidence of the overall benefit of cardiac rehab. It's essential that we collect, analyze, and report our own program data to show evidence of quality. Reporting performance measure data allows us to link our patient outcomes to our own program processes. In addition, measuring performance enables us to show what we are doing well and to share those successes with our own team, with administration, with payers, and with regulating bodies. It also allows us to find those areas where adjustments need to be made and to improve our performance by creating quality improvement projects and remeasuring. And finally, it allows us to determine whether our important goals of providing high quality care and of improving patient outcomes are being achieved. Performance measures are used for regular systematic collection of data. They zero in on selected components of our program and how they affect patient outcomes and progress toward goals. Carefully chosen performance measures can also be a reflection of the overall quality of our program. And of course, they must be valid, reliable, and feasible. There are a number of questions the committee considered in selecting measures that are meaningful, including those listed here. First, is the measure related to a meaningful patient outcome? In other words, do increases or decreases in the value of this measure relate to improved or worsening patient outcomes? Secondly, can the outcome be reliably measured? Is the method of measurement reasonable and clear so that data is reproducible? Is the measure clearly defined? Is it clear who and what is included in or excluded from the numerator and the denominator? And importantly, can the data be used for quality improvement? Can something be changed within our program that would alter the outcome for this for the better? And then finally, is it important enough that measurement of this performance measure reflects the overall quality of our program? Of the 10 core components of cardiac rehabilitation, exercise training maintains perhaps the most prominent position in comprehensive cardiac rehab programs. There's no arguing the strength of evidence for benefit of exercise training in reducing cardiovascular disease risk. Evidence links exercise training and improved functional capacity to both improved cardiovascular function and to a reduction in overall cardiovascular risk. Exercise training has a positive effect on a wide number of cardiovascular disease risk factors, including reduction in systolic and diastolic blood pressure, improved insulin sensitivity, improved high-density lipoprotein cholesterol and decreased triglycerides, decreased body fat, and improvement in psychosocial distress. But perhaps one of the most significant benefits of improved functional capacity is its mortality benefit. Improved functional capacity is indeed one of the strongest predictors of survival in patients with cardiovascular disease. In fact, evidence shows that for each 1 milliliter per kilogram per minute increase in peak VO2, cardiovascular mortality is reduced by approximately 10%. For every 1 MET increase in functional capacity resulting from cardiac rehab, all-cause mortality is reduced by 25% at 1 year. And for each increase in 6-minute walk distance of 104 meters, risk of myocardial infarction and risk of all-cause mortality decreases by 47% and 55% respectively. And finally, 1 MET increase in submaximal exercise intensity during cardiac rehab training decreases all-cause mortality by 34%. The substantial benefits linked to improved functional capacity and its effect on improved overall patient outcomes make it hard to argue the importance of measuring and reporting this factor. The question then becomes, is it realistic to see the magnitude of change in functional capacity necessary to affect patient risk and survival as a result of cardiac rehab participation? A number of studies have measured increase in functional capacity as a result of cardiac rehab participation. Some have used a symptom-limited graded exercise test. The average increase in functional capacity from pre to post-program was 1 MET, or about 25% increase, using this method of measurement. The change in submaximal exercise capacity during cardiac rehab exercise sessions has also been studied. Results from these studies have shown approximately 3 MET increase in submaximal exercise capacity from pre to post-program participation. This translates to about a 77% increase in submaximal functional capacity. And finally, research measuring distance walked on a standardized 6-minute walk test before and after cardiac rehab has shown an increase of 59 to 75 meters following cardiac rehab participation. This is in the range of 15 to 19% improvement in functional capacity. So the answer is yes, sufficient evidence exists to both include functional capacity as an important measure in cardiac rehab, and evidence that improvement in this measure can be expected as a result of participation in a quality cardiac rehab program. So shown here is the performance measure for improvement of functional capacity in cardiac rehab. The measure was written to include the level of improvement necessary to affect change in cardiovascular mortality and risk. And it reads as follows. The percentage of patients who increase their functional capacity after participation in cardiac rehab is measured by one of the following assessments. 1, a symptom-limited graded exercise test showing an increase in METs by at least 15%. Second, estimated exercise session peak METs showing an increase in METs of at least 40%. And 3, a 6-minute walk test with a distance increase walked of at least 10%. Taking into consideration the wide variability in patients and their ability to improve functional capacity, the performance measure uses a conservative threshold for achieving this measure. The numerator includes those patients who actually meet the performance measure, and it's defined as follows. The number of patients who increase their functional capacity by the percent specified in the measure description from beginning to completion of their cardiac rehab program, as measured by either symptom-limited graded exercise test, estimated peak METs during an exercise session, or 6-minute walk test distance. Completion of the program is defined as a patient who has undergone a final formal discharge assessment session and updated treatment plan. In addition, for this performance measure, the patient must have completed at least 4 weeks of cardiac rehab, as this was considered the minimum of amount of time necessary to achieve significant improvement in functional capacity. The denominator includes all patients who have completed the cardiac rehab program and who do not meet the exclusion criteria. And it reads as follows: the number of patients who complete cardiac rehab during the measurement period. A patient is defined as having completed cardiac rehab if he or she has completed a minimum of 4 weeks of cardiac rehab and undergone a final formal discharge assessment session and updated treatment plan. There are only a couple of pretty straightforward exclusions to this measure, and these exclusions are as follows. Patients who cannot participate in either a symptom-limited graded exercise test, a 6-minute walk test, or who cannot exercise on equipment that can be accurately calibrated for MET estimation would be excluded from the measure. These patients should not be included in the denominator. Additionally, patients who do not complete at least 4 weeks of cardiac rehab should not be included. So there are 3 options of measurement for this performance measure. Obviously, the same measurement method must be used at the start and at program completion. The first method is a symptom-limited graded exercise test, and this is considered to be the gold standard measurement if performed at program entry and at exit. Testing would be done using a standard testing protocol from the American College of Sports Medicine. And to meet the measure and be included in the numerator, the patient will show a 15% increase in estimated maximal MET level from pre to post-program completion. Since a substantial number of cardiac rehab programs do not require or receive graded exercise testing data before or after cardiac rehab participation, the second measurement option is to report an estimation of submaximal MET level achieved during the cardiac rehab exercise session. This data will be collected at the beginning and again at completion of cardiac rehab. The third session would be used as the beginning session to allow for patient learning. So instead of the very first, the third session would be used as beginning. The MET level should only be used from equipment that can be accurately calibrated using ACSM calibrations. Factory calibrated equipment may be used. It is understood that most programs do not manually calibrate their equipment. But keeping that in mind, the treadmill would probably be the preferred modality of equipment. Consider that this can be most accurately calculated for MET level, probably followed by the cycloergometer. However, keep in mind that the same type of equipment must be used for pre and post measurement. To meet the performance measure using this measurement technique, an increase of 40% in submaximal MET level would be measured and reported. And the third and final option for measuring functional capacity is the 6-minute walk test. Again, this would be completed at the start and again at program completion. The program must use a standardized testing procedure as published by the American Thoracic Society. And to meet this performance measure, a 10% increase in walk distance would be measured. Slide is understandably hard to read, but I wanted to show you the flow chart that can be used to determine whether a patient would be included in the performance measure. So starting at the top, the first question would be, did the patient complete at least 4 weeks of cardiac rehabilitation? Again, the definition is that they completed cardiac rehab if they underwent a final formal discharge assessment and updated treatment plan. So if a patient did not complete 4 weeks of cardiac rehab, they would be disqualified from this performance measure. If the answer is yes, the next question is, did the patient complete one of the following at program entry? Either a 6-minute walk test, a symptom-limited graded exercise test, or use of an exercise device that can be calibrated for accurate estimation of MET level. Again, if the answer is no to that question, the patient is not included in the denominator. If the answer is yes, they would be included in the denominator. The final question is, did the patient then show significant increase in functional capacity at program completion using the same method of measurement as at program entry? Significant increase is defined in this measure as a 6-minute walk test increase of 10% or more, graded exercise test increase in MET of 15% or more, or an estimated peak MET level during an exercise session using the identical exercise equipment of 40% or more. If the patient did not meet one of those levels, they would not be included in the numerator. If the answer is yes, they would be included in the numerator. So to calculate this performance measure, the numerator is divided by the denominator, and the percent of patients who increased their functional capacity after participating in cardiac rehab can be determined. Let's move on then to a couple of examples. The first example is a 60-year-old female who had a percutaneous coronary intervention. Her medications include aspirin, a beta blocker, and a statin. At her third cardiac rehab session, she walked on the treadmill at a 2 MET level, and she completed 10 weeks of cardiac rehab. During her final session, she walked on the treadmill again at a level of 3.2 MET. So the first question is, would this patient be included in the measure? And the answer is yes. She would be included because she completed 10 weeks, which is obviously more than 4 weeks of cardiac rehab, and she walked on the treadmill during her third session and again on her last session of cardiac rehab. The next question would be, does this patient meet the functional capacity performance measure? And the answer is yes. She had a 60% increase in her peak METs on the treadmill, so she would be included in the numerator as meeting the functional capacity measure. Our next example is a 70-year-old male who has a diagnosis of coronary artery bypass graft surgery with chronic systolic heart failure. His medications include an ACE inhibitor, a diuretic, statin, beta blocker. He completed a 6-minute walk test during his first session and completed 210 meters or 689 feet on that 6-minute walk test. He completed 8 weeks of cardiac rehab, and at the final session did another 6-minute walk test, completed 225 meters or 738 feet. So again, we would ask, would this patient be included in the functional capacity measure? The answer is yes. This patient completed 8 weeks of cardiac rehab, so they meet that criteria. And he also completed a 6-minute walk test on both his first and at his last session of cardiac rehab. Did the patient meet the functional capacity performance measure? In this case, the patient did not meet the measure. His 6-minute walk distance increased by 7%. And remember that to meet the performance measure, that distance would have to increase by 10%. So this patient would not be included in the numerator. And our final example is an 82-year-old male with a diagnosis of myocardial infarction and percutaneous coronary intervention. His medications include a beta blocker, statin, and antiarrhythmic. This patient completed 2.2 METs on a recumbent bicycle and 1.8 METs on a treadmill during his third cardiac rehab session. He completed 8 sessions or 3 weeks of cardiac rehab, and on his last session he completed semi-recumbent stepper exercise at 2.4 METs. So the first question is, would this patient be included in the performance measure denominator? And in this case, no, the patient would not be included. He would be excluded because, first of all, he completed 3 weeks of cardiac rehab, and the criteria is that he complete 4 weeks. Secondly, if you look at the type of exercise completed in the cardiac rehab program, he completed recumbent bicycle and treadmill exercise on his third session. He completed only semi-recumbent stepping exercise on his last session. So there's no way to compare the MET levels achieved on those various pieces of equipment. So this patient would not be included in the denominator. In conclusion, I'd like to highlight just a couple of key takeaways. First, it is more important than ever to collect and report data that provides evidence of benefit of our programs. The performance measures are selected based on their importance in affecting positive patient outcomes, the ability of the cardiac rehab program to make a difference in the measure, and whether they reflect the overall quality of a program. Because of the substantial benefits realized from improved functional capacity, including improved patient survival, measuring improvement in functional capacity during cardiac rehab participation is considered extremely important. The improvement in functional capacity can be measured using a graded exercise test, a 6-minute walk test, or submaximal peak estimated METs during cardiac rehab exercise session. I've included some selected references from the performance measure document for your information. And I'd like to thank you for the opportunity to provide you with information on the functional capacity performance measure.
And thank you, Anne, so much for sharing your expertise. We hope you all found this webinar to be useful and will apply this material in your home program. Thank you again for attending and have a great day.